The problem is you do see a lot of antisocial people succeed. Loneliness is as big a risk factor for ill health and death.
We live inside our heads.
You go cold turkey, you go into withdrawal.
There is a lot of value in the stuff that we struggle with.
Better Thinking. Conversations with experts exploring all things psychology. Welcome back to Better Thinking. My name's Nesh Nikolic, and my guest today is Dr. Lydia Brown, here to talk to us about menopause and mental health, as well as self-compassion and aging. Lydia is a senior lecturer in the School of Psychological Sciences and a member of the Brain and Mental Health Research Hub. After receiving her PhD on self-compassion and menopause in 2015, she completed postdoctoral training at Harvard Medical School and the University of Melbourne on healthy aging. Her research focuses on understanding and enhancing well-being during the menopause transition and in the second half of life more generally. Alongside research, Lydia has worked as a clinical psychologist for a number of years, supporting adults to manage mental health conditions such as depression, anxiety, and recover from trauma. Outside of research, Lydia is a meditation practitioner and has spent a number of months living in a Sri Lankan Buddhist monastery. She is interested in the translation of contemplative practices to our culture in ways that do not lose the heart and soul of traditional practices. It was an absolute pleasure interviewing Dr. Lydia Brown with regards to her research. I think she has a lot to say and is able to tie some nice points together that really speaks to what half the population is going to experience in a kind and compassionate way. Lydia, a big thank you for coming onto the show today. I'm excited to talk about menopause and mental health in general, and also about how we age. I think it's something that doesn't get too much attention, yet is so important because the whole world's going to go out and experience it either individually or as a partner or a loved one or someone who's associated with caring for and loving others. We're all connected beings, so I think it's nice to talk about this topic, and pleasure to have you on. So I appreciate you coming on.
Thanks, Nesh, for having me. And it really is a topic close to my heart. Menopause in specific, but also aging. It's a universal topic. We will all age. Half the world's population, if we're lucky to live through midlife, will go through menopause if we're born with a uterus. So that's women, but also more generally those born with the uterus. So that they are really universal topics. But I feel that in psychology, we don't always play a lot of focus to the second half of life. So really looking forward to the conversation.
You're spot on. Aging, menopause, these things don't come up. They certainly didn't come up very much at university in our training either. So it's lovely and I think refreshing to have these conversations because, as I said, it's a part of life that needs some highlighting. Maybe we could begin with how did you get into this topic? What brought you towards understanding this, studying and so on?
It's slightly long story, but I think it's relevant. So I was in my early 20s. I just finished an arts degree and I had a scholarship to begin an honours year in politics. And I decided, though, before starting, to spend a month in a Sri Lankan Buddhist monastery. Mm-hmm. There was a civil war going on at the time. My family weren't that happy about me choosing Sri Lanka of all places. But I just felt a bit of restlessness in life. I felt like I was doing the right things. I was, to an extent, achieving, also enjoying being in my 20s, enjoying parties, hanging out with friends. I was doing all the things that are meant to make you happy, but I really felt like something was missing. And I thought back to a time when I was a teenager and meeting a Buddhist monk who was from Sri Lanka, and he was working with dying people and with cancer patients at the Austin Hospital in Melbourne. And he had a kind of wisdom and happiness about him that I had never, ever seen before. I made a note of that at the time. I didn't pursue it. But when I was finishing the degree, about to start honours, I thought back to him and thought, I absolutely have to visit him in Sri Lanka. He'd moved back to Sri Lanka at that time. And so I booked my tickets and went. And that time was very transformative, and it really has changed my life path. So why that relates, it doesn't sound like that's got anything to do with menopause or aging. But at the end of the month, after learning a bit about meditation, I tried to start my politics honours, and I realised, hang on, this is not my passion. I don't actually know a lot about politics, and everybody else in my cohort were really, elated and excited to be talking about the current political situation. And I just kept thinking back to Sri Lanka and thinking back to meditation in the monastery. I was never a great meditator, by the way. And so I gave up that opportunity, and I decided to work in the community as a carer. So working with people who were disabled, who had dementia, who had terminal conditions like motor neuron disease, working in that caregiving role. And wherever I could, when I'd saved enough money, I'd go back to the monastery and spend more time learning about meditation and these inner practices. And when I was there at those later points, still in my early 20s, the longest time at the monastery, I was there for 5 months. But I came and went for smaller amounts of times too. And for me, there was not really many people my age there. There weren't many Westerners there, full stop, because of the unsettled situation. But those who were tended to be in midlife or older, and they were at often really difficult points in their life. So somebody had been diagnosed with quite late stage cancer. Somebody else was dealing with an adult son who had a heroin addiction. And so these people who I got talking with, they were often older than me in midlife, and they were really up against some of the most challenging experiences you can imagine in their lives. And they'd come to this place to learn about their mind and their heart through these contemplative practices. And so I felt a degree of connection, even though we were different circumstances, different age. And I wanted to become a Buddhist nun, actually. I shaved my head. My parents were horrified. But there was a turning point there as well. I had 2 Buddhist nuns who I worked closely with. They would look after me and teach me how to wash my clothes on a stone, which I never really mastered. It was always a bit of a disaster. But they, were great, very knowledgeable about Buddhism. But one day I came back, I think I was attending a funeral, and I came back and one of the nuns was cutting off her cast. She'd broken her wrist. And I thought, oh my goodness, I've never seen anybody break their cast off before. And I started, they used scissors of some sort, I think. But I said, what's going on? Like, what are you doing? And they said, oh, well, we've spoken to the Ayurvedic doctor, and he said that we should not use a cast, that we should use these Ayurvedic herbs, and that's going to create a better outcome. And it was a turning point for me, because my heart did sink a bit, because I thought, I respect that as your truth, but I can't share that truth. And if I really am to stay here and become a Buddhist nun, I don't know if I can be, removed from science. And so something shifted there. Another thing that shifted for me was how women are treated in Buddhism. So the 2 nuns that I lived with, they were midlife as well. They were perhaps around 50, but they had to bow down to teenage monks, teenage men who were ordained, just because of their gender. And that really did not sit comfortably. I found it quite surprising. I later learned that Buddhist nuns were not allowed to receive the same ordination as men. And again, from my upbringing, I thought, how could I put myself in that position where women are placed second to men, have to eat second, get their food second? So those 2 turning points, I guess, made me think, okay, how can I integrate some of these things into a Western context? And that's when I started the long process of retraining as a psychologist in my more mid to late 20s. So that's sort of a bit of a long story, but I feel it's relevant because it explains the interest in the inner world and also the interest in some of the most difficult and universal issues that we face as being human, like physical sickness, physical symptoms, and aging.
Sounds like those two pivotal times, question some really strong beliefs or understandings, value sets that struck a nerve with you, in a similar sense that the way that you lent into your practice struck a nerve and something resonated, changed and then pushed you in that direction. What would you say your learnings were at the time, if you don't mind me asking, before we kind of move on? How did that strike you, and how did you change from that?
So I was never a great meditator. I'd love to say that my learnings were I became an amazing meditator and I mastered my mind and I was never troubled by anxiety or stress or unhelpful thoughts. But I did start to get a glimmer of an idea that happiness is not always to be found in the outer world, because we will inevitably face challenges, many of which we can't control. We can't control if we might get a health diagnosis one day. We can't control the fact that we are aging, that our bodies are vulnerable. Even, we can't always control even our mental health at times. And so rather than trying to control our outer world or to try to sort of strive for happiness, I really did get a taste that, no, I do think that the answer is more inwards. If we can understand our own heart and mind, that might help us to navigate some of the inevitable challenges of life more skillfully.
I really like that phrase, happiness is not found in the outer world. It's so profound, very hard to practice, but incredibly profound. And it then poses the question, well, how do you then cultivate that inner world while also living in the outer world? We're both in and out, and depends on our focus. One might dominate the other, and for good reason. We sometimes do need to be very much in the outer world and other times very much in the inner. So thank you for sharing.
And there's so much to do in the world, right? And I love being involved with research, practice, teaching, clinical psychology. These are all outward facing, but if there's a bit of synergy or a bit of balance between our own inner state, and if we can try as best we can in an imperfect way to focus on that, but also to be very engaged in the outer world and getting that balance, I think any inner work we do might help us to give back on a larger platform, actually.
And how did that all lead you to finding an interest in aging and obviously the process of aging and what happens for us?
So I love the universality of aging, and it was also a little bit subversive even in psychology. There was a lot of focus on youth mental health, which is so important, and mental health prevalence rates are high in early adulthood. But for me, I wanted to do something a bit different and something that spoke to those inevitable universal challenges. And so I learned of a supervisor, Christina Bryant, who's a psychologist at Melbourne University, and she was working in the menopause space. And originally it was to do an honours project looking at menopause. It turned into a PhD. So under her guidance, I was able to really kind of hone into this interest. And it was actually in Melbourne that I discovered self-compassion as a construct, as a psychological construct to begin with. While in Buddhism, where I went, they spoke a lot about cultivating compassion and sharing compassion with others. But I think they almost took self-compassion perhaps for granted, as if it was assumed that you will be friends with yourself. But here in the West, we really can't assume that. I think that we're taught growing up to be good people, good girls, good boys. We're taught how to be kind to others. We're taught the language to use if we want to have healthy relationships with others. But we're never explicitly taught how to think or how to treat ourselves. And especially in moments of life when things go wrong, nobody tells us how to do that, or if we make a mistake or if we fail. And so it was the West that started researching the construct of self-compassion based on Buddhist principles, but in a more scientific way. From about 2002 onwards, Kristin Neff is really a founding figure in this field of science. And over the past, couple of decades, the field has really exploded. So I learned about it here and at a meditation workshop from a midlife woman. I remember her. She was also talking about menopause. So the two went together from the very beginning. And when she said self-compassion, I thought, oh, okay, interesting. And on my way home, I was getting a haircut. I was a student, and it was from a trainee studio. And she was so slow. And I just started to notice my own inner dialogue. I was thinking to myself, you idiot, you should have known that it would be a bad idea to get a trainee to do your hair. Yes, it's cheap, but look how long this is taking. You've been here for 2 hours. She hasn't even cut your hair yet. You're going to get behind on your work. You should have known better. So this kind of dialogue, and I could feel myself tightening up and feeling not great. And then I remembered, oh, hang on, I had just learned about self-compassion. Okay, how could I change my dialogue here? And then that was a bit of a moment. I was like, okay, I've learned about meditation, but there's a missing link. How can I actually be a bit kinder to myself? So I really thought from that personal perspective, wow, what a great topic. And then I was luckily able to integrate it into my research.
It's a nice segue to ask you about your research and what the topic was, what you found. I imagine you had to read extensively to write a PhD on that as well. But maybe talk me through that a little bit.
Yeah, sure. So this was I graduated from my PhD back in 2015. So in the years leading up to that was when I was doing the initial research on menopause and women's mental health here in Australia. We had a data set of women living in rural Victoria and New South Wales. And we were really just looking to see if self-compassion might be relevant to the experience of menopause. So at first it was a cross-sectional study, and we were looking to see, we measured, a number of constructs relating to menopause, the menopausal stage, and particularly hot flushes and night sweats. So that's really the hallmark menopausal symptom. And it's the symptom that causes the most distress on average for women. And it's also a very common symptom over the menopause transition. And so up to 80% of women can experience these hot flushes either during the day or at night. They can impact sleep, impact your concentration, your mood. So I was interested in if self-compassion certainly wouldn't take hot flushes away because they're a physical phenomena, but might they help us relate to those hot flushes more skillfully, such that perhaps they have less of an impact on daily life? So that is what we found. We found a number of things. There were a number of different studies, but that was one of the key findings was that, you can't always control how many hot flushes you have, but for any given number of hot flushes that a woman might have, for those high on self-compassion, they tended to find that those hot flushes were less impactful on their daily life. And that had spill-on effects for depressive symptoms as well. So it was a cross-sectional study, but it showed that self-compassion might be a really relevant factor to help women manage menopausal hot flushes. But again, I'm certainly not saying that self-compassion would somehow take hot flushes away, because they are a physiological experience.
What would you hypothesize, or what does the research say if there is a more direct link that self-compassion does? What is the moderating factor of that makes it more accepting or bearable to have these hot flushes?
It can be helpful to think about the ingredients of self-compassion, and maybe I can try to relate it to an example I had even last night. So there are three ingredients of self-compassion: mindfulness, self-kindness, and common humanity. And these three factors work together to shape your thoughts, your feelings, and your behaviors. And there's sort of connections, I would say, to cognitive behavior therapy, but we can talk about that perhaps later. But so say and especially in moments of suffering, especially in moments of some kind of a challenge. It could be a small challenge like misplacing your keys, although that can also be a big challenge. But it can is also relevant in the really big life challenges, such as a divorce or a health diagnosis or loss of a loved one. So especially in these moments of suffering, self-compassion looks at how do you relate to yourself. Mindfulness involves the ability to really be there as a witness of that experience. And that sounds easy, but it's not as easy as you would think. And perhaps you've seen as a therapist, often clients will say, oh, my work's really difficult, but so many people around the world are suffering more than me, and I really shouldn't be so stressed about this. And that's true, but it's not true that they shouldn't be stressed about it, but it's true that there's always going to be somebody that has suffered more. But mindfulness is really a skill of seeing your own experience with all its sort of validity. So last night, I have a 7-month-old at the moment. She woke up and I couldn't really get back to sleep very quickly. And so rather than saying, no, you're not suffering, this isn't a big deal, mindfulness is like, okay, you're a bit stressed right now because you want to go to sleep. It's seeing that suffering in that moment rather than pushing it to the side. And then comes, there's not really an order, but the next one can be self-kindness. So rather in a moment of difficulty than beating yourself up, like you might be thinking, oh, gosh, you should just be back asleep by now. You did all the right things. Why can't you sleep? You've got a lot to do tomorrow. You're kind of failing here. That kind of critical voice. Self-compassion involves the opposite of like, this is a moment of suffering. May I be kind to myself? I don't have to fix this, but just really being there for yourself in that moment. With a bit of warmth and kindness, just like how you would share those feelings with a friend. And then common humanity. So whenever we're suffering, it's quite easy to feel isolated in your experience because you're often the only one with those exact set of circumstances. And so in a way, you're kind of thinking, well, I'm the one in bed awake, and it feels quite isolating. Or I'm the one going through a divorce, and so it feels isolating. But common humanity is exactly the opposite. So rather than feeling isolated in our experience of difficulty, it involves acknowledging suffering or stress is part of what it means to be human. It's really what unites us as part of the human race rather than what divides us, although the extent of suffering differs, of course. And so if we can see our own experience as linked to common humanity, there are people around the world also who are struggling to sleep right now, or with hot flushes. I'm part of a community of women around the world who are experiencing these. It can help to kind of counteract that isolation and move towards common humanity. So when you look at the three ingredients of self-compassion, these can be the mechanisms by which self-compassion can improve our mental health, and perhaps create some healthy behaviors in our life. Through those three pathways, I guess.
Each one of those ingredients is so potent in and of themselves, and I hear so much of the Buddhist philosophy, very much of the ACT framework, very much it borrows from many psychological frameworks and practices, but I really love how it's broken down and looked at as ingredients so that each one stands alone. It almost provides a little bit of a, if I talk about it as a psychoed or a bit of a structure in what I can kind of lean back on because they are identified as separate things. That mindfulness as being a witness, non-judgmental, an observer, is just so powerful in and of itself, and it doesn't cast criticism. It just says this is what's occurring right now. It's not good, bad, right or wrong. It's just saying this is the experience, and I'm present with it. And as we know, that can be both when there are pleasurable things occurring and not so pleasurable, and both can be kind of heightened or mitigated or moderated. Yeah, the self-kindness of actually being thoughtful to whether it's, if I put into an ACT perspective of diffusion, observing those thoughts and not necessarily taking on automatic thoughts. If we go on the CBT approach, it's a posturing, a position, a way to stand, with oneself, which I think is really lovely. And that last one, the common humanity. I mean, how validating and normalizing is that one of the beautiful things that I've experienced as a parent is there's this common bond that all parents that unites us. My wife and I, we certainly in the younger years of our children, like what you're talking about, we used to call other parents, zombies. There's some other zombies walking around because they all have that telling sign of bags under their eyes. Their eyelids are a bit heavier. You can see that there's been months of interrupted sleep. Yet, everyone's still trying to put a smile on, and because we're still enjoying life, of course, but there's a commonality. The denominator is even the prime ministers of the world have all wiped bottoms. There's something beautiful about that. That even the rich and powerful have to do all of those things and be vomited on. It's humbling. It's beautiful. There's a shared that commonality. So that's a really nice structure. I'll be using that in my therapy for sure, because I think it's nice to spend time talking about what self-compassion comprises of, rather than just a term.
Yeah, and also to realize that it relates to your thinking styles. Some people even can connect into the physicality of it. Like, how do I feel in my body? Am I feeling tense and sort of anxious? How can I bring a little bit of warmth and softness to my physicality? Even something like a self-compassionate touch of placing your hands on your heart or gently stroking your arm, to connect in with the idea of caring for yourself in your physicality. So thoughts, feelings, and also behaviors. So thinking, well, what does self-compassion look like to me? And a little question that can get into that is, what do I need right now? Asking yourself that question, what do I need right now? Because even to ask the question, you already have that acknowledgement of a difficult moment. You've got the mindfulness there. And then the question is an invitation to, to self-kindness. It might be like, actually, I need to stop what I'm doing and go and get a warm cup of tea. Or it might be, I'm studying, I've got a deadline, I've got to submit this assignment by midnight tonight and it's 11:30. I can't get a cup of tea right now. What I need is to take 3, slow, deep breaths and just go back to what I'm doing. So that question can be a bit of a prompt, and the answers differ. And that's certainly not, it's not an invitation for self-indulgence or to kind of give up on ambitions and your goals for the future.
And I like that, because there's a nuance between what do I need, or potentially if I replace that with want, and what I might want might not be available right now, but it still adds a clue as to what I might want to introduce later, or how I might want to approach this situation in the future. There's so many things of looking at the need or the want that, there's a nuance there, which I think is important, and hence why, contemplative practice is so important, that it's not deterministic, but rather curious. It's a conversation. It's mindful. It's thoughtful. It allows for questions to be posed and to be wrestled with, even when it's complicated, because there's many driving forces going on, quite often, all the time. Values conflicts, is a common one.
And sometimes if you ask somebody what they want right now, they'll often say, if they're stressed or suffering, I want it to stop, or I want it to go away.
Yeah.
That's a want, but then what do I need right now? Often it's,
Yes.
I need a bit of gentleness. I need a bit of kindness.
Yes. And that's probably even a nice practice potentially, about being able to ask both, because they could be different, and they can be swapped depending on the context. Coming still from a curious place, sometimes both will say the exact same thing, or the answer will be the same for both. Yeah, lovely. And how if you don't mind me asking, how did your research measure self-compassion? Is that a self-report on based on series of questions? How were you measuring it? Was there a particular scale? Was that something that was already designed, or something that you've created?
No, so back in about 2002 or 2003, Kristen Neff developed the self-compassion scale. So it's a 26-item scale, validated scale. There's a short form version now that's a bit briefer, but you can go ahead and complete the test yourself online from Kristen Neff's self-compassion website. It's being used in a lot of research around the world now. There are thousands of studies that have looked at self-compassion, its connection to health behaviours, motivation, well-being, psychopathology in clinical settings. So it's quite a widely used scale. And there's also an intervention course, the Mindful Self-Compassion Program, which is similar to MBSR, mindfulness-based stress reduction, in that it's across 8 weeks. You're invited to do meditation practices or self-compassion practices between sessions. So there's that interventional work as well. More recently, I actually haven't, I've sort of focused a little bit more on the menopause and mental health itself, although I've continued to work on self-compassion, but in the last couple of years, I've sort of more taken a deep dive into looking at menopause and mental health more generally as well.
What have you been focusing on in particular? What's caught your attention in that space?
Yeah, so it's a very interesting space. And it even gave me pause for this conversation. I was kind of thinking, do I really want to talk about some of the challenges in the menopause and mental health world? But I think it is worth talking about. So I graduated back in 2015. And I really wanted to continue work on menopause because I felt like it's such an important topic. I myself will go through menopause one day, so perhaps selfishly I thought I could, it is a personal interest for that reason. And I felt like there was a lot to do. I felt like some of the menopause symptom scales that I was uncovering, some of the language felt quite dated. I wasn't quite sure why some symptoms were deemed symptoms of menopause when I dug into how menopause symptom scales are developed. And so I really thought there was a lot of work to do. And I, explained to mentors and peers, this is really what I wanted to spend a lot of work on. And I was told multiple times, look, menopause is quite a niche area. If you're really serious about research, you probably have to think about another topic in aging. Maybe you should consider researching dementia or diabetes. These, you'll find funding there. But if you menopause is going to be an uphill battle. And I thought, wow, niche area? Like, really? Is menopause more niche than dementia? Like, how does that actually, I don't know how the numbers would make that to be the case. And at first I kind of thought, no way, that's not true. But really, what I found is that I did find opportunities to continue research in slightly adjunct areas. So not menopause, but topics like, building resilience in the context of diabetes or late cancer or dementia. And so I published in these other areas of aging, still very interested in self-compassion and still really interested in aggregating data. So this is sort of less, I've got these two parts of me. One is more about the contemplative practice, very gentle self-compassion, but the other part of me is quite interested in numbers. And to me, I thought, well, I can do one research project and I can collect one set of data and we'll have some findings, but how transformative is that? And I thought back in my PhD, I was already thinking, well, isn't it better to spend some of my time combining data from around the world or look at all the data ever published in a particular field? Because then we can make some much bigger findings and bolder findings, and maybe the research is going to have be more impactful. And so that got a real interest for me in conducting systematic reviews and meta-analyses where you do sort of combine all the known evidence in a particular field to understand what's really going on with a degree of sort of accuracy and nuance that you really can't get from a single study. So I moved away from menopause research in a paid form. Funding came to do other research, but I was able to continue with projects through, sounds like free labor, but through like master's students and honours students. We turned our cross-sectional database into a longitudinal database through the assistance of students who I'm, ever grateful for, and I think have really enjoyed working in this space as well. But then it was about 3 years ago, there was this opportunity to come back based on some of my expertise around the meta-analyses, systematic reviews, plus my expertise in menopause, to work on a Lancet series on menopause and mental health. So I've been working on that with Professor Martha Hickey at the Royal Women's Hospital and colleagues, really experts in menopause from around the world, from very esteemed organisations and institutions, and it's been a really exciting, but at times a bit political process, and that was just published earlier this year.
In what sense do you say political?
So going into the project, I really thought that menopause and the menopausal transition or perimenopause, that time when your periods are irregular leading up to your final menstrual period, this tends to happen on average when you're in your late 40s, on average lasts around 4 years. This was a window of very significant vulnerability for increased risk of depression. And I took that to mean depressive disorders, so that you're very much, that you might be doubled to potentially quadrupled the risk of experiencing depression during the menopause years. And people have linked that back to changes in hormone levels and how that might increase the risk of depression. Also menopausal symptoms like hot flushes, how that could perhaps, lead to this increased risk. But not just a small increased risk, which is what you might expect for many reasons, including having hot flushes. They've not always been treated very well due to clinicians and GPs in particular not feeling confident to treat them. So if you're living with very, with difficult hot flushes that are impacting your sleep, impacting your concentration, that aren't treated or maybe even being dismissed in a doctor's office, then of course that's going to increase, a vulnerability to some mental health issues because you've got this untreated medical symptoms. But so going into the project, I really thought, okay, it's a window of quite significantly, increased risk. But as we really dug into the data more and more, and over a 3-year process, you become quite an expert in available data. We focused on longitudinal data because that offers a higher quality of evidence than cross-sectional work. Then I started to think, oh, hang on, I think that this might be a bit over-pathologized. of course, some women do experience depression during menopause, but when I really dig into the data, I wasn't seeing the level of psychopathology that I'd heard about a lot from, some other experts or from podcasts, from, on TV even. So so there was a sort of bit of a discrepancy there, which I guess surprised me.
And was it sort of felt like it was political because when you spoke about that or uncovered that or showed the data around that, it wasn't received particularly well, or it's an uncomfortable thing to,
I guess.
because
So I had a
conflicts with other
newborn.
evidence?
The Lancet paper was published back in March, and then I gave birth around a few days later, actually. So it was very weird timing. So I was feeling perhaps a little bit vulnerable. And, some people would say that was because of changing estrogen levels. For example, there is a big estrogen withdrawal after birth. And, maybe for some people it's that, but, and maybe it was for me, but I feel like it was more a normal vulnerability of having just given birth, having having this young baby to care for, disrupted sleep. The paper had come out and we got some, really wonderful feedback from around the world. It was a very exciting, moment in my career. But, there was also a bit of a backlash. For example, there was a petition that I think, 200 clinicians from around the world signed, and they were saying that, this is really shocking because we see women suffering every day in our practices. And for you to be talking about mixed findings or talking about possible over-pathologizing of the mental health burden of menopause, that's, really shocking, and we don't really agree with that. And so I found that quite interesting to hear those types of conversations come up, because for me, I was sort of more thinking apolitically. I was thinking about data. I was thinking about what I happened to see on the page. So yeah, it's been quite an interesting experience to look at this kind of through a political lens as well, especially given that I quit my honours in politics.
But you didn't quit being human, right?
No.
And then humans come in and can politicize anything. It's fascinating how we can hold a position so tightly, because it's so much removed from the scientist practitioner. The scientist practitioner tries to say, this is what I observe. This is what the data is telling me. I'm actually trained to not put inferences on this. No different to, it would be foolish to say that estrogen changes is the actual narrative in the story that means you feel X, because we just simply wouldn't know. It's very different to say that we have got science that or data that's being collected that says that people's emotions can change based on hormonal levels. But to go out and put on an individual basis, I get that's the way that we think, but we take lots of shortcuts, and hence the value of mindfulness, and the value of the scientific method when done very well, that we should be actually, in actual fact, celebrating and encouraging is saying, hey, Lydia, this is really exciting. Let me have a look at the data, because maybe I've been misinformed, or maybe my data comes from somewhere else. But I'd be excited about hearing about a meta-analysis or a systematic review that goes out and changes things, because it informs how we might support people differently. Because I think there is also a very real danger around how we use language, how we speak about these things. Even the word symptoms is concerning to me, rather than saying, experiences that come in a menopausal period, because symptom kind of infers you shouldn't be having it. And if we think about the acceptance model, the self-compassion model, a part of that goes out and says, what does the common humanity do? They feel the same things. This isn't a symptom, potentially. I get we could call it a symptom as well, but it might be a shared common human experience that women all around the world have, and all differently as well. And that's a different story to disturbed sleep. Disturbed sleep is different again in its actual effects that it can have. It's different to try and relate to disturbed sleep differently to hot flushes, for example. But self-compassion can be useful in all of it. But it is surprising to hear a petition was put together to, rather than applauding and encouraging and saying, I can still hold a different point of view, but good on you and well done with your research. That's a big body of work.
But, there's such diversity in experience of menopause. And I've seen firsthand in my practice that women absolutely can be going through enormous suffering. And a lot of it is actually, unfortunately, unnecessary suffering because our medical system isn't, fully across menopause. I've heard of GPs who have been told, like a friend going through GP training, her mentor said, look, I'd stay clear of menopause if I were you, refer to a specialist clinic because it's too confusing. That's just so sad. And that's changing. Wow. And with the Senate inquiry into menopause, we really are starting to realize, no, GP, this is not a niche topic. GPs do need to be educated and feel confident to manage and treat symptoms, and especially the hot flushes and night sweats. And also with the estrogen changes, like some women, can certainly be more mood sensitive to those changes than others.
Yeah.
And what, data shows is that for those with a personal history of major depressive disorder, there could be an increased risk of relapse at that time. And also some data does say that there may be an increased risk of depressive symptoms during the menopause transition, but it appears to be much lower and more nuanced than what was previously thought. So it's not that everybody is likely to, experience significant depression during their transition, but rather some women with risk factors may. And I think that nuance is difficult perhaps to put onto a TikTok, and it's maybe not that... I don't know, maybe it's not that shocking or, it's a bit subtler, but I think it's a really important message. And I think for me, probably a hopeful message, because I hope, when I go through my own menopause in maybe 10 or less years, that, I might be a better version of myself, that I might, but also, if I do have impacts on mood or symptoms that we've got a culture and medical care that will support me to be that better version of myself.
And that's why it is quite concerning when we hear things like, stay clear of menopause. And you could replace that and say, stay clear of puberty. This is something that's going to happen. And I think it does require a nuanced conversation about what does depression look like from a clinical point of view versus mood changes and changes in life, changes in identity. There's so many different things. And no one here is saying that women aren't going through a tough time at transition, at change. There's so much complexity there. But if the data is not saying that the numbers are what they've been stated as previously, we're not removing anything from women. We're actually trying to have a more nuanced conversation. We still want primary care to be involved because there are things that can mitigate some of these things. I'm not a medical professional by any stretch of the imagination, but for some women, some medical intervention could be very helpful. For others, not, but at least we can have a conversation rather than being frightened of a stage of life, and have an open conversation about saying this is kind of how it looks, and let's be interested rather than, let's not talk about menopause, let's stay away.
Yeah, but it's that medicine that's been neglected for a really long time, and lately we have seen, we've got an attic of medicine that's been neglected. Let's go on and have a look. And I think maybe our culture is trying to do a bit of a pendulum shift to that and really shine a light on this topic that has been neglected for so long, which is essential and it's long overdue. But any area that's been neglected, when you turn the light on, some of the resources are not sort of up to where they could be. And so, you might, it takes a bit of time to start to really build that high quality evidence base. And so then it becomes a bit of a balancing act, because on the one hand, you want to share important information with clinicians and with women, but on the other hand, you don't want to jump the gun. And, without that evidence base, start to kind of build, clear recommendations. It does need to be founded in good evidence. So I think that's, the key area that's needed at the moment. But again, in a fast-paced society where there are so many TikToks and even podcasts and, when people want change now, to balance those two things is a bit tricky.
Hence why long-form conversation, nuance, proper research as well that can provide guidance and recommendations that actually comes from somewhere rather than a series of assumptions. What is the current standard of practice? What are the current guidelines when someone goes out and let's say is hitting those late 40s and they start either experiencing or they're noticing some initial changes? What usually happens? What's like a common story? I know they're all very different, but what's a common story and what's the common standard of practice that occurs?
So the most common symptom that you might experience first could be changes in the regularity of your menstrual cycles. If you have menstrual cycles that aren't regulated by something like a contraceptive pill, and then you might go and have a conversation with your doctor. The most common physical symptom would be like hot flushes or night sweats. And women really do report a lot of other symptoms. And, so it's not just the hot flushes and night sweats in and of themselves, but I think as researchers, we're still trying to understand the core symptoms versus the possible variety of symptoms that are there. But hot flushes and night sweats are certainly a key one. And so and then really a first point of call could be to speak to a GP. But then sometimes not all GPs feel comfortable. I actually spoke recently to a client who had quite severe hot flushes, and I said, I really do think that you need to follow up about this. And when she spoke to her GP, the GP, it was amazing, but this literally happened. It was last year. Said, oh, look, my wife coped with these hot flushes, and really there's nothing I can do. And really, I think you're going to be fine. And just to think, wow, how could a GP in Australia in this day and age say something like that? It's really, really disappointing. But if you look at GPs who might be, say, affiliated with the Australian Menopause Society, then, or finding GPs with an interest in menopause, then that can be a really great start.
Is there quite effective medications that can be offered to women, for example, who have got quite significant, uncomfortable experiences, maybe symptoms we call them? Is this something that is readily available, can be offered easily? Is this part of a standard practice, but it's just not necessarily widespread at the moment? Well, what's the state of play, so to speak?
So my expertise is, I'll definitely answer your question. My expertise is more around like the mental health side of it.
Sure.
And in terms of the treatment of physical symptoms, I tend to kind of more refer to doctors, medical doctors, to speak about the nuance of that.
Sure.
And it really depends on people's particular profile, their particular symptoms, their personal history. But, hormone replacement therapy or menopausal hormone therapy, it's now called, can be a very effective treatment for hot flushes and night sweats. But at the moment, there are supply issues, which is really problematic. So I wouldn't say that I'm an expert on the medical treatments of physical symptoms, but there are also non-hormonal treatments for hot flushes as well that are available.
But I suppose what you're highlighting is it's a bit disappointing in that particular case that there wasn't an extended conversation about, hey, there are things that we can do. You don't have to necessarily do them. There's HRT, you can see a psychologist, see how you can manage it differently. I'm sure there's a series of other things. It was more of a kind of a dismissive, this is just something you can, others have done it. So you can too. It's,
Remarkable.
dismissive. And look, that might be valid and accurate for a lot of things. Someone can break their arm and their arm can be repaired without going to the doctor, but it's not necessarily advisable.
Exactly, like a cast, evidence. We've done a lot of evidence. We've found that casts for arms. Again, I'm not across all of that evidence, but I believe that's an effective treatment. And so we want to really lean on the treatment, the evidence where we can. There is a good end to that story, though, although kind of good, kind of disappointing in that there was a delay. And so another example of this unnecessary suffering that women do unfortunately endure around menopause. The delay here. So the doctor, I said, look, I think you need a second opinion. That doesn't sound right to me. The client took, effort and time to get that second opinion from another GP who also didn't feel comfortable making any kind of prescription at that time. She referred on to a specialist menopause clinic, but that had a wait list. So my client was, having to continue to experience these untreated symptoms. Eventually, she then went to the Royal Women's Hospital Menopause Clinic here in Melbourne, and then she was prescribed. In her case, it was, a menopausal hormone therapy treatment. And now finally there is a good end to that particular story. But yeah, it's an example of some of the issues that some women are facing at the moment.
What is the current research saying about best practice within psychology in terms of how psychologists, and if we extend it out as well, other health professionals, counsellors, OTs, what can we do on that level, but maybe a little bit of focus on the psych side?
I think in terms of mental health at midlife, to not assume that symptoms are necessarily symptoms of menopause. So I think it could be problematic if a GP was to say, oh, well, look, she's struggling to get out of the house. She has, lost interest in life. She's really down. And then for the GP to kind of ascribe those symptoms to menopause could be problematic because it could delay treatment options, the best treatments that we know to treat depression, like CBT, referral to a psychologist, and also antidepressants. But if that patient has co-occurring problematic hot flushes, then yes, the hormone therapy may be really helpful. So not assuming that menopause will cause is the cause of suffering at midlife is important, but also at the same time acknowledging that it can absolutely be a factor, potentially the main factor in some cases, but there's that diversity of experience. And then looking at that holistic care. So, appropriate follow-up. If a GP did suspect there might be some mental health concerns, considering a referral to a psychologist. If menopause is at play, I'd hope that they would have the skills to manage that. And, encouraging women to really consider their own well-being at this time. So midlife is at a low point for satisfaction with life for both genders. In our 20s, that we have a lot to enjoy in life, a lot of parties, a lot of freedom. There's all this hope for the future. But research, quite strong, high quality research says that on average, satisfaction of life does tend to bottom out around midlife. And so we have to be quite proactive in exploring, okay, well, what does bring me joy at this time? How can I change things? Maybe things you were striving for before, like a mortgage and children, maybe you've reached those goals, or maybe you haven't reached those goals and you've let go of some of them. But there can be a real turning point of, rather than accumulating more, of thinking, okay, well, who am I and what do I love? What do I want to pursue? So taking that opportunity, within yourself to kind of reflect on some of these things, and satisfaction of life does tend to improve. So we grow. It's not a sad story, because over time, through our 50s, 60s, and 70s, the satisfaction of life tends to kind of go up, and we tend to really get that satisfaction again. So there's that hopeful message at the end as well.
I think that's so important, that obviously your research points to as well. It's too easy to dismiss experiences that are similar of nature to just say, oh, that's menopause. When in actual fact, that period is also highly correlated with lots of challenges. Our responsibilities are very high. Career questions. We're actually coming to grips with a different body than we've ever experienced, in terms of we experience that natural aging. I believe there's lots of hormonal changes both for women and men. I believe for men, your testosterone starts to drop, in your 40s. So there's lots of things that are going on, and to just dismiss it to being one thing or another. I think the beauty of doing a meta-analysis is to try and look at what is all the data saying, and be informed, so we can pose other questions. So we can say, let's not jump to a conclusion. That doesn't mean that people don't need help. Of course they do. We're not going out and saying anything like that. And this is, I think, the human problem is we are afraid of we're afraid of losing a position, rather than being open to saying, I've learned something. How beautiful is it to change my mind? Otherwise I remain blinded. And so, I think it's important to still examine and question and look at research for its merits, because I know that there's lots of problems with the replication crisis and the like, and hence why leaning into meta-analyses and large.
This particular Lancet piece was a bit broader than a meta-analysis, so we didn't combine quantitative data, but we reviewed data in general longitude, and we looked sort of at mental health in quite a broad. Not just depression, anxiety, psychosis. We considered quite a lot clinical recommendations, so there was quite a lot happening in the paper, but it wasn't a meta-analysis.
Yeah, but it's important that there's room for all these conversations, rather than being squashed and saying let's make this political, and you're not allowed to have an opinion. But I understand it as well. We are human. We're complex. We're defensive as well, and I'm defensive. I'm defensive on a lot of things. Don't get me started on many things.
But maybe it's when you have the young baby, like I had. And interestingly, I also had hot flushes, and I didn't know what they were. So after you give birth, you have an estrogen withdrawal, and for the first few weeks, I was waking up in a big sweat, and I thought, gosh, I better see the doctor. I must have an infection. And then I realized, hang on a second, these are hot flushes. How did I not know that when I've been studying this for years? I didn't even recognize my own hot flushes, and they certainly did impact my sleep, that's for sure. I was drenched in sweat.
It's so fascinating when we're able to become aware of something or recognize something, the power that we can take it away from it. Not suggesting that the hot flush isn't still disturbing and waking you up and so on and so forth, but at least your relationship with it. I remember having what I'm very confident was a panic attack at one stage when I was driving, and after sort of getting caught up in it for maybe 30 seconds, a minute, I recognized that, wow, this is, I think, what my clients have been telling me about. And I was actually able to kind of laugh at it, chuckle to myself as to how powerful and visceral it was, my immediate response was, there's something wrong. I've got to go to hospital. It was so visceral, but being able to just even recognize it, I could actually, I was very curious. I was interested. I was actually almost somewhat thankful because I could kind of understand what others were experiencing. So I lost the fear of it quite instantly. And not suggesting that this is how people should do it, or can get any inferences, but just noticing the relationship. So when you talk about your hot flushes, that's a change in your relationship. This is an inner world experience.
I wasn't incredibly self-compassionate. I was more like, oh my God, I'm drenched in sweat. It wasn't deeply self-critical, but it was kind of anxiety, like, this is awful. It wasn't a really compassionate dialogue. And I think had I labeled it sooner as, oh, this is a hot flash, this is what I've been researching for the past 10 years.
Yes.
And then, how can I practice what I've researched? How could I practice some self-kindness and self-compassion in this moment? But you have to label it. It was very helpful to be able to label it first, and then you've got that gateway.
And I hope a conversation like this also lends itself out to listeners to recognize the normality of going through a period of life, but also the normality of seeking support and help. Also the normality of we don't have to point to it immediately to describe everything that we're experiencing as well. So there's a individual experience for everyone, and to be open to that. Before I let you go, can I ask you, where can people find out more? Where are good resources if people want to continue this conversation, whether they are anticipating menopause, whether they're currently in menopause, whether they are, a lot younger and interested in the topic, or just have an interest at all. Someone could be in their 80s listening. Where are some good resources or websites and the like we could kind of point to?
So for self-compassion, I do really think that Kristen Neff's website, selfcompassion.org, is great. She's got a lot of guided practices. It's quite old now, but it's still very relevant. Her TED talk on self-compassion might be a decade old, but it really gives a nice overview. And the opportunities for how you can actually practice that skill are on that website. And in terms of menopause, you might want to cast your eye over the Lancet Series, Lancet Series Menopause to look at. It is sort of scientific, but it does cover. It's taken a number of years to bring together this work, and it covers a lot of the evidence around menopause, and the Australian Menopause Society as well, and including like links to GPs that are connected or have an interest in training in menopause is another recommendation.
Absolutely fantastic. Thank you so much, Lydia. I just want to say, I really appreciate you coming on, taking the time, your work. I think there's something also brave about allowing and publishing the data and standing up for what it says, despite some of that backlash, so to speak, being a voice for menopause. And I can also see that the influence of your early year practices in your language, and I imagine that's integrated through the way that you do your research and just life practices in general. I know that obviously that wasn't your path, and there were some differences there, but I can still see much of the value that can be received from those types of practices are still in your language. So it's beautiful to hear as well. So thank you, and appreciate all of your work.
Thanks, Nesh. It's been a real pleasure to spend all this time talking about topics that I really care about.